Let's talk about children and some of the characteristics that may lead to obstructive sleep apnea and other breathing disorders while they sleep. There are several childhood symptoms of obstructive sleep apnea, and a lot are similar to adult symptoms. During the night, a child that has obstructive sleep apnea may show snoring, oral or mouth breathing. This can mean either puffing through the lips or the jaw hanging open. They may show diaphoresis, which is sweating, restlessness, enuresis, awakenings, parasomnias, and excessive chest wall movements. It's unusual for a child to have obstructive sleep apnea without also having snoring. Obviously, the snoring stops once the airway is totally cut off and the child has an apnea, but as they fall asleep, and when they are not apneic, they are typically snoring. There are a few reasons kids may breathe through their mouth. It could include nasal blockage or an inability to move air through the nose, or a tongue tie in which the tongue does not rest at the roof of the mouth, allowing the jaw to fall open. When respiratory events occur, there is a rush of hormones that arouse the body, and those can make the body do funny things like wet the bed and sleepwalk. Excessive chest wall movements could include paradoxing effort. Babies don't breathe with their chest. Have you ever noticed when boys reach a certain age, they start to puff out their chest and breathe with their chest out instead of their abdomen? That's shallow breathing. When you pour water in a cup, does it fill up from the top down? No, not on this earth. Air is the same way. The diaphragm contracts, creating a vacuum, allowing air to enter the lungs, and the abdomen expands first, and then the lungs and chest. When a person has trained themselves to breathe shallow, they're not getting the full capacity of air. Babies don't know about breathing with their chest. You should see most of the movement in the abdomen. When the chest muscles get involved, that means they're trying harder to breathe for some reason, and that's abnormal. When the child is awake, you can expect them to have normal wake ventilation. However, they may still breathe orally, and they may have something called hyponasal speech. Hyponasal speech is the sound of speech that results from too little air escaping through the nose. It's as if someone has a stuffy nose. It's hard for these people to pronounce the letter M, for example. Let's see what happens. M. Yeah. Because of nighttime disturbances and awakenings, the child may experience behavior disturbances and somnolence. If the child has anatomy that is severely obstructive during the day as well, they may have noisy sounding breathing. Also, a term with infants and very small children called failure to thrive is a classification that describes a child who is not following normal growth trends. They're not growing like they're supposed to or are expected to. And this can be from malnutrition, poor sleep, poor environmental conditions, illness, poverty, and many other issues. Because of this, they are on the opposite end of most adults who have obstructive sleep apnea who are typically overweight. Children are smaller than they should be. Pediatric sleep medicine is still very new, newer than sleep medicine for adults, obviously. But keep in mind how difficult it is to perform research on children. And for that reason, we have very little data to quantify an AHI which needs treatment, which treatment is appropriate for this age, and how often sleep studies should be performed. There aren't even very many PAP masks to choose from. An AHI of 1 may be statistically significant but because the child did have a few events. An AHI of 5 or more is considered clinically significant, as it should be. It would also be clinically significant if the patient experiences oxygen saturations when they accompany respiratory events. That's the limit at which CPAP can be prescribed for children, AHI of 5. Adults typically are offered therapy around 15 an hour, but they can qualify if they have comorbidities, like if they have high blood pressure, diabetes, things like that. They can typically go down to 5. Occasionally, a sleep study can be deferred if a significant obstruction is observed by medical personnel or documented by recording. Because of the limitations on data surrounding child sleep apnea, providers have the ability to prescribe treatment without a sleep study. But how do you prove sleep obstruction if the child doesn't sleep for you? I don't know. That's part of why it's controversial. When the diagnosis is uncertain, or if a child has a high surgical risk, a sleep study would be recommended. Surgical risk is determined because the first line of treatment for children with sleep apnea is a tonsillectomy, granted that the child has sufficient tonsils to yank. The tonsils act as part of the immune system protect against infection. In particular, they're believed to be involved in helping fight off pharyngeal and upper respiratory tract infections, like COVID. They're made from lymphoid tissues, and they are found just in the back of the throat on either sides bilaterally. If you look with my laser, this is a tonsil, and that's a tonsil. The adenoids are a little higher, and they're up here. You can't really see it on the other one, but these are the adenoids. And these pictures are kind of strange because there's depth here. You can't see it because it looks like it's on the surface, but that's inside. That's behind things. The adenoids are a little higher and a little further back behind the nasal passages. These are the nasal passages here. Air comes in, and there's the adenoids. The adenoids also have infection control properties. These two features, those are the two favorite features that ear, nose, and throat doctors are quick to remove if they are deemed troublesome. If we look at the diagrams, we can see the little punching bag at the back. There's the uvula, and that goes that hangs down from the roof of the throat. And the ceiling that it hangs down from is called the soft palate. In order to standardize how providers measure how big tonsils are, someone came up with the tonsillar size index. This index has to do with how much of a throat is visible past the tonsils. So a TSI of 0 indicates that tonsils have either been removed or they're so small that they're totally contained inside the tonsillar fossa, which is a little like a cave in which the tonsils are supposed to fit. A TSI of 1 plus indicates tonsils occupy less than a quarter of the lateral dimension side to side of the oropharynx as measured between the anterior tonsillar pillars. What? That means the tonsils aren't big enough to cover up more than 25% of the airway from left to right. That's it. Can you see 75% of the airway? That's what we're looking for. The index continues to increase by percentiles until the TSI of 4 plus is reached, where more than 75% or more of the space of the throat is opening where the tonsils are is obstructed. That means all you see are tonsils and nothing else behind it, or just a little window of light. Here are the 4 indices. There is a problem with the possible inflammation fluctuations a patient may have over time. The tonsils can be inflamed chronically, all the time, or acutely, just some of the time. We can see these in these pictures the space between the tonsils, laterally, left to right, space between the tonsils. Gets a little smaller, and here you can't really see anything. You can see maybe that little bit right there. Depending on how much of that space you can see is which index that patient falls under. If you have trouble finding a quarter, just find the halfway point and then divide that in half. So right there to there, it's about a quarter. The Mallampati score is a classification of airway crowdedness with more than just the tonsils. So this is more inclusive than the TSI. This is where you view the pharynx, or the back of the throat, with the mouth open at rest. A Class 1 demonstrates full visibility of the both tonsils, a full uvula, and the soft palate or near where the roof of the mouth meets the opening of the throat. So that means you can see everything in the back. We want to see the thing that hangs down, the uvula, the thing that it hangs down from, the soft palate, and back of the throat, and both tonsils. Class 2 Malampati indicates visibility of the hard palate, which is the roof of the mouth that you can feel with your tongue in front of the punching bag uvula. Those are also the maxillary bones of the roof of the mouth. Also visible is the soft palate, but only the upper portion and of the tonsils and uvula are seen. I've got a slide after this where we can actually see all this stuff. Class 3 shows further obstruction where only the soft and hard palate are shown with the connection of the uvula or the base of the uvula. This also brings in where the tongue is. The tongue can take up a lot of room. Class 4 Malampati indicates the hard palate as the only visible feature. Scores have controversy in regards to how well they correlate with the prevalence of sleep apnea, meaning it doesn't really predict if someone has sleep apnea. But if there's a high score, that does tend to show a greater chance for sleep apnea. So here you go. The tongue looks like it's blocking most of the airway, and that has a lot to do with it. But you also don't see the craniofacial features like fatty tissue or bones that may contribute as to why the tongue is so upwards and protrusive, especially up here. Look how high that is there. There are many reasons, but it's just not an indicator of sleep apnea, just an indicator of who might be at risk. Enlarged tonsils do not always mean sleep apnea, but if a child has sleep apnea and enlarged tonsils, that will press the scalpel of an ENT to remove them. So why are they enlarged? Are people just born with big tonsils? Sometimes. But also, sometimes the kid gets sick and they can be inflamed. Okay, that's one reason. A tongue tie can also cause a child to sleep with their mouth open, causing the tonsils to become inflamed from all that dry air that is not supposed to go in. The common practice is to not care why the inflammation happens. It's all about getting rid of the tonsils, and that's a huge problem. Number one, it reduces the immune system from fighting off infections. Without the anatomy there, it has less infection fighting power. There was a study that showed increase and worsening severity of infection in those who had their tonsils removed. It seems as though people think if you remove the tonsils, the infections stop, which is not true. Kids are going to get sick, and the infection is just going to go elsewhere. Also, the indices of children who had their tonsils removed for sleep apnea purposes are of high probability to still suffer from sleep apnea later in life. It is uncommon that only one anatomical feature causes obstruction, like your tonsils or adenoids. It's generally the combination. When you saw that Malampati, you saw how the tongue can be displaced. That tongue can be displaced for a multitude of reasons. Tonsillectomies may work for a while, but there is no cure. Tonsillectomies are only performed on children because of the risk of scar tissue. Scar tissue is the buildup of connective tissue after healing from an operation. That tissue is incredibly tough and thick, and it's not flexible and malleable as the soft native tissue was. If that's the case and the airway just collapses, this scar tissue can make the obstruction even worse. So kids still have some stem cell capability there so that when they are healing, they've got more native skin connective cells, but we don't take those things out of adults unless it's an emergency, because that can really be tough. Ankyloglossia or tongue ties are midline deformities in children and are pretty common. Midline deformities are things that happen down the midline. The first sign of a tongue tie is usually painful breastfeeding. Because the frenulum cuts off the tongue's mobility, the thing under the tongue, this is the frenulum right there. And this, you can point the tongue all the way up. You should do this in the mirror. Can you, with your mouth open and your jaw open, can you touch the top of your roof of your mouth with the tip of your tongue? That's the frenulum right there. This one is very tight. Because the frenulum cuts off the tongue's mobility, the infant can't suckle properly, so it uses other parts of the mouth in an attempt to get more nutrition, and that hurts the mother. Infants who are misdiagnosed can be malnourished and labeled failure to thrive if they do not meet certain milestones with weight and growth. Later in life, a person may have trouble speaking, playing wind instruments, licking ice cream, things like that. Also, the natural resting place for your tongue is at the top of your mouth, the roof of your mouth. Over time, that constant pressure elevates and shapes the palate to its adult shape. Without that, the palate becomes narrowed, and that causes more obstruction. So when the tongue is not against the roof of the mouth, it's on the floor, which is right next to the airway, potentially causing obstructed airway. If you just try breathing with your mouth closed and your tongue down, like all the way down, and hold it there and try and breathe, my breathing does not feel very confident. It doesn't feel very good. But if I've got it out of the way under the roof of the mouth, I'm okay. The tongue in its natural, relaxed, elevated position keeps the jaw elevated and the mouth closed. When the tongue is on the floor, the jaw is more difficult to hold closed. Therefore, the patient may sleep with their mouth open. The body is made to breathe nasally because it's got hairs for filtration, capillaries near the surfaces to warm the air, and mucosal membranes to moisten the air to make it perfect for the lungs. Through your mouth, all that is gone, all those preventative measures. And then your mouth gets dry, your tonsils get upset and inflamed, especially if obstruction causes snoring. That's even worse. It makes them even more pissed off. A lot of pediatricians see enlarged tonsils and are quick to remove them. There's a lot of research that is pointing away from tonsillectomies, but pediatrics still use them regularly. The treatment for ankyloglossia is a frenectomy, which is usually a laser that vaporizes the tissue. The younger the patient, the better. Typically, actually a week old is optimal. And that sounds aggressive, but a breastfeeding baby needs nutrition, and there's really no time to waste for that kind of thing. The longer you wait, that's more development and growth that's happening without that tongue position. Here's just one article depicting tongue ties as a proponent for sleep apnea. There are many, although the trend in seeing this disorder is not very old. I wrote a research paper on this in 2019, and when I began my research, there was only one mainstream article about sleep apnea and tongue ties. After 2 years, there were more than 12. The rates of obstructive sleep apnea in children is rising mostly due to the obesity epidemic that continues to blunt childhood health. Currently, between 6 and 18% of children snore, and 2% of children have obstructive sleep apnea. There's a peak in lymphatic tissue growth between the ages of 2 and 8 years old, which shows some ownership of the tonsillar hypertrophy and why it's popular to remove them around those ages. Children in the African American and Asian communities, as well as post-pubescent males, show the most prevalence towards obstructive sleep apnea. No one can really diagnose a child with sleep apnea just by looking at their chart or really just by looking at the patient, but there are some markers that can lead a provider to believe that a child is at risk for sleep apnea. As previously mentioned, obesity is a big risk factor for obstructive sleep apnea. 25 to 40% of children with sleep apnea are obese. The fatty tissue caused by obesity pushes the walls of the throat together, and it decreases the area through which air can move in and out. Down syndrome patients are also severely high risk, with somewhere between 50 and 100% suffering sleep apnea. This is due to the characteristic craniofacial features like macroglossia, narrow nasopharynx, and generalized hypotonia, low muscle tone. A diagnosis of sleep apnea may be delayed because of many of the symptoms of sleep apnea and Down syndrome are so similar. For instance, being sleepy, behavioral problems, and enuresis are both found in each disorder. An adenotonsillectomy may relieve some symptoms, but it's never a cure. Children with, mucopolysaccharidosis. Mucopolysaccharidosis, there it is. Children with mucopolysaccharidosis are at high risk for developing sleep apnea. Mucopolysaccharidosis is a group of disorders caused by a malfunction of an enzyme needed to process some carbohydrates, or what we would call macronutrients, like sugars, things like that. These special carbohydrates are unable to be processed, are called glycoaminoglycans. Glycoaminoglycans, and they're responsible for bones, skins, connective tissue, things like that. That, personally, that kind of thing is not on the test. You don't need to know what mucopolysaccharides are. You need to know that it will cause sleep apnea, because in more than 50% of these patients, it has sleep apnea. And what happens is it causes too many of these mucopolysaccharides in the soft tissues, causing breathing problems and hypertrophy of the tonsils, adenoids, tongues, and mucous membranes. The breathing problems can become fatal. And scoliosis is part of it as well. That's when the back doesn't go straight up and down. It has some left and right crookedness. In my research, craniofacial defects are one of the main causes of sleep apnea, especially in those who have genetic disorders like Down syndrome. The prevalence of sleep disordered breathing is approximately 40 to 50%. There are many craniofacial disorders. All of the ones we are about to cover have many of the same symptoms, and they are all mostly caused by premature suture closure. Because of these early closures, the head does not grow normally. Why do we have these sutures? So that when the head grows, the skull doesn't stop it from doing that. So when the skull has fused, when those sutures have developed and the skull's hard, the brain can't grow normally. They all also appear to have an underdeveloped jaw and an affected face shape. For Apert syndrome, the patient may have fused toes or fingers, known as syndactyly. With Pfeiffer syndrome patients, they may show bulging wide-set eyes and a clover-shaped face. A high-arched posterior palate, meaning the roof of the mouth is high in the back, is a common indicator for sleep apnea, and all these patients have that. All of these disorders are pretty rare. Congenital central hypoventilation syndrome. That's when patients, while sleeping and sometimes awake, take shallow breaths, thus retaining excess carbon dioxide. For some reason, these patients have a defective central nervous system that does not regulate the gas exchange well enough. Treatment like PAP therapy during the night and even a diaphragm pacemaker can assist. Congenital sleep CCSH. How about that? Congenital central hypoventilation syndrome, also known as CCSH. Out there, that was HS. Let's do that. CCHS can cause cyanosis, which is blueness of the skin like the lips, edema, which is excess fluid buildup, typically in the extremities, and right-sided heart failure, meaning the lung side and not the systemic side. CCSH is CCHS is usually caught upon examination due to home concerns or an apparent life-threatening event, an ALTE, which may have damaged the centers of the brain controlling respiration. So, who's Ondine and why is it her curse? Well, it's when we appear to breathe reasonably well while awake, but you have severe hyperventilation during sleep, which is basically what CCSHS is. So, Ondine, story time. Ondine was a mermaid, daughter of Poseidon, god of the sea. Mermaids were immortal, but they can lose that immortality if they marry a mortal. Of course, Ondine fell in love with Hans, a knight. So she married him, lost her immortality. Just like the man he was, Hans grew tired of Ondine and left her for another woman. Poseidon got pretty upset with Hans and placed a curse on him. The curse meant that none of his automatic body functions would work unless he consciously willed them to happen. And the story ends with, that'd be kind of funny if, well, we'll not go there. The story ends with Hans trying not to fall asleep because knowing he will die because he will forget to breathe. I have personally titrated one CCHS patient once. We had to get the capnography data as well because this was such a rare and important case to get right the first time. This particular patient was fixed with nasal pillows and bilevel, with the rise time and a specific cycling setting. We'll learn all about that stuff in PAP titrations if you haven't already. Acquired central hyperventilation syndrome is pretty much identical to congenital central hyperventilation syndrome, but it's acquired, meaning it was not from a parent genetically, but from the environment or some other disorder intrinsically. There are many causes for acquired central hyperventilation syndrome, including brain tumors or lesions, infections like encephalitis, trauma like a head injury or car accident, congenital vascular malformations, meaning the blood vessels didn't grow properly in certain parts of aren't getting enough blood. Neurological surgery may also disrupt parts of the brain unintentionally. There might be central nervous system radiation and cerebrovascular trauma, which that sounds like a stroke. Obesity hyperventilation syndrome is when patients are unable to lift their lungs under the excess fatty tissue because it's so heavy. There's also less space within the thoracic cavity for the lungs to expand fully. Increased adipose tissue in the upper airway also becomes obstructive when the patient lays down. When these patients sleep, their breathing is much worse because they are naturally going to have lesser breaths while sleeping, and it's going to exacerbate their problems further. The way we figure out if a patient does in fact suffer from obesity hyperventilation syndrome, it can be validated with capnography data, which would manifest as hypoxia, low oxygen, or hypercapnia, high carbon dioxide. Pickwickian syndrome is a term coined by Charles Dickens in the 1800s, and it's synonymous with obesity hyperventilation. He wrote a piece called The Pickwick Papers, and in it he describes a man by the name of Messenger Big Joe. Dickens was very detailed in the description of Joe. He was overweight, he snored, he was sleepy during the day, and had heart failure. Specifically, Pickwickian syndrome patients have extreme morbid obesity, alveolar hyperventilation with hypercapnia even during wakefulness. Alveolar hyperventilation just means ventilation. They just want to be more fancy. Secondary erythrocytosis, which is too many red blood cells in the blood, and also right-sided heart failure. Neuromuscular disease is an umbrella term that describes conditions that negatively affect the nervous system, specifically the peripheral nervous system anatomy, which includes structures like muscles, nerves, and neuromuscular junctions. Examples of these disorders include amyotrophic lateral sclerosis, or ALS, GNE myopathy, multiple sclerosis, or MS, and muscular dystrophy. This can cause weakness in the respiratory muscles and atelectasis, which is excess mucus. That's when excess mucus obstructs airway passages, kind of like pneumonia, Without muscles to control breathing, hyperventilation occurs and worsens during sleep, causing severe arterial blood gas derangements without symptoms. That just means the blood or the oxygen and carbon dioxide aren't being managed well enough, and the blood gases are really out of whack. Despite all this happening, the patient won't feel anything or describe symptoms. However, the patient will still suffer sleep-related daytime problems like excessive daytime sleepiness and morning headaches. All children with neuromuscular disease will eventually develop respiratory disturbances during sleep. Neuromuscular disorders do not historically get better with age. Peripheral arterial tonometry, PAT, is a device that measures blood volume in the fingers to see if the body exerts sympathetic tone or autonomic features. The whole point of these devices is that even though sleep architecture is preserved due to no cortical arousals, the autonomic arousals are disrupted to sleep. Children may have trouble promoting arousals from respiratory events, so these detect if a patient is having a subarousal. When a patient experiences obstruction, that leads to an increase in sympathetic activity, meaning the body is trying to fix it. Vasoconstriction means blood vessels are tightening the blood vessels to get blood around quicker to respond to something. Vasoconstriction, the blood vessels are tightening, and that in itself makes the blood go faster. If you have too much of that, it is hypertension, high blood pressure. Unless these are accompanied with a sleep study, these values are inaccurate for sleep purposes. The pulse transit time measures arterial wall stiffness, and it works by measuring the time it takes for a pulse wave to travel from the heart to another pulse site like the brachial artery. When the blood pressure drops, the stiffness in the arterial walls drop and leads to a longer transit time. When the walls are stiff, the blood moves quicker or transits quicker. The thoracic cavity may have too much air leaving because of all the respiratory effort the body trying to breathe, and that can drop systemic blood pressure, causing a longer transit time. But then the pulse transit time becomes shorter again after respiration resumes post-arousal. These may be used in different research labs or specialty labs, but these are not used in common sleep study practice. All right, so that's it for this one. Join me again for the next breathtaking presentation.